This is a clinical trial that I'm going to present that is not yet active. It is something that is in development and being written. The protocol is written, and we will hopefully activate in the next few months. But I just thought I would take somewhat of a neoadjuvant therapy approach in kidney cancer. Uh, Here are my disclosures. And I'm going to be talking about two different strategies. One is in metastatic disease, where neoadjuvant immune based therapy really, that is what we should start with. And the question is, should we even do the surgery or not? And then the BLAZE trial is the pilot trial of belzutifan versus pembrolizumab versus combination of the two in locally advanced renal cancer. So, neoadjuvant therapy principles, in my view, in metastatic disease, you want better responses by starting immune checkpoint or systemic therapy first, due to the antigen spread from the primary tumor and potentially improving PFS and OS in the future. In the VEGF TKI era, that principle did not pan out. So cytoreductive nephrectomy did not show an advantage. But I would argue that in the immune checkpoint therapy with a completely different mechanism of action, there is adequate rationale to consider at least a study of cytoreductive nephrectomy with the PROBE trial. In locally advanced disease, I think our goals are somewhat different. And as Vitaly mentioned, you definitely want to improve the quality of the surgery with, especially for the tumor thrombus patients, improve resectability, control tumor thrombus, preserve renal function in some patients where, that is a critical piece that makes us stay away from surgery, and of course, improve long-term outcome. So this is upfront versus deferred nephrectomy, a relatively recent paper, a meta-analysis where a third of the patients in this study had received immune checkpoint therapy also. And basically what it showed is regardless of the therapy, upfront deferred nephrectomy was the way to go. And we knew that somewhat from the SURTIME trial with a small study, again, upfront versus deferred with sunitinib. So that leads us to the ongoing PROBE trial, or the Southwest Oncology Group S1931. Primary endpoint is overall survival. Everybody with synchronous metastatic disease, as in having the primary in place and metastases, is eligible. They are started on any of the FDA-approved IO-based regimens. And then depending on if the patient has lack of progression, because obviously if they have progression, they need to change their systemic therapy. But if not, then they can be randomized to get nephrectomy or not. All the patients would continue on the systemic therapy because they are deriving clinical benefit. So that is the sum total study design of the trial, and it is ongoing. It's about 160 patients or so, but we do need active participation and help with conducting this really important trial. Okay. Now moving on to how we assess some of these novel agents or even existing agents in the locally advanced setting. And this is our study where Udit Singhal is one of the junior faculty members at University of Michigan, and he was mentored, and Naomi and I worked on this study together. This is a study that is supported by Merck, and now we are going to be opening it through the DoD Kidney Cancer Consortium, which Eric Jonash is leading. So this is the study design of this trial, multi-center phase 2, randomized somewhat, but very preliminary, small numbers. Anybody with T2 through T4, any lymph node involvement, and M0, clear cell cancer, would then get either belzutifan single agent, 120 milligrams standard dose for 12 weeks, or pembrolizumab for 12 weeks, and then the combo belzutifan plus pembro for 12 weeks. And again, at 6 weeks, if there's progression noted, you can, of course, stop and go directly to nephrectomy, partial or radical nephrectomy, depending on what the urologist thinks is the perfect procedure for the patient. Sample size estimate is about 18 evaluable patients per arm. These patients will be followed for relapse-free survival, overall survival, etc. One of the interesting things here is we're also exploring neoadjuvant pembrolizumab, which, as you know, in melanoma and in other tumors, neoadjuvant immune checkpoint has, just by changing the sequence, has dramatically improved outcomes. So these are the primary objective: to evaluate efficacy of belzutifan and pembrolizumab monotherapy or in combination. We have picked a composite primary endpoint, which really has not been tested so far. And the reason being that RECIST can be somewhat misleading, especially with immune checkpoint therapy in the mix. It is hard to derive an exact RECIST response and use that and only that as a decision maker of response. So we have picked this composite endpoint of either partial response or complete response, I guess, or the pathologic response rate, which will be defined as 25% or less of residual viable tumor in the nephrectomy specimen. So that is our study design as of now. In conclusion, I would say that neoadjuvant studies will be a valuable addition to therapy. The biggest thing I think it will help with is studying resistance pathways, as well as it could help us use those as surrogate endpoints to evaluate some of the novel agents relatively quickly in kidney cancer, which now, of course, the bar is so high, even in metastatic disease. If you pick overall survival as an endpoint, you're waiting years for the outcome of efficacy. Then, as I mentioned, melanoma, neoadjuvant pembro, just by flipping the sequence, you were able to make a big impact on progression-free survival. So that may hold true for kidney cancer. We just haven't looked at that. So this so far has been studied only, neoadjuvant therapy in kidney cancer has so far only been studied in small case series or phase 2 studies. And it is time eventually with some of these pilot data to pick the right combination to take to large phase 3 trials. Thank you for your attention.